Since it's arthroscopic, you're going to make very small incisions, but in order to figure out the placement, the physician will actually palpate landmark anatomical structures such through the skin, such as the patella, the tibial tuberosity, and you're going to actually make some portals here, and you're actually going to draw with a pen. You can outline the patellar tendon. Make sure you don't damage some of the underlying structures, such as the infrapatellar branch of the saphenous nerve, which would be found kind of just below this porthole that's already been drilled here. So the portals also will allow your access for your tools and then your camera in order for you to conduct the surgery. Okay, the first step would be the preparation of the tibial tunnel. You're going to insert what's called a tibial guide. It's kind of like a C-shaped clamp. I don't have one here. So then what you're going to do is you're going to drill through this tibial guide through a hole, and you're going to go through the anteromedial tibia. You're going to move upwards into the joint space, out through the native footprint of the ACL, which is just anterior to the intercondylar eminence of the tibial plateau. And you're going to leave the guide wire in, and then once the graft size has been determined, you're going to select a corresponding fluted reamer that will maximize soft tissue graft to tunnel interface, and you're going to drill over the guide wire all the way into the joint space. And that would be the completion of your tibial tunnel. And then what you'll do is you'll insert a tool. It's like a rotating shaver device. It's a sucker shaver, and it'll come inside and it'll debride all of the broken fragmented tissue and scar tissue or whatever you have in here, because you want to have in bone tissue as well, because you want to have this tunnel cleared for smooth graft passage. Okay, now that's completed. Now the next step would be the femoral tunnel preparation, so you can provide a femoral fixation point for your new graft. In this position, you're going to select one of two approaches. The first approach that used to be the most common is called a transtibial approach, where you actually pass through the tibial tunnel in order to start the drilling of your femoral tunnel. But the problem with this approach here is that if you were to look at this intercondylar fossa as a clock, with this top portion being 12 o'clock, coming through the tibia here, you're going to hit an angle that's about 11 to 11:30 on the clock, which is actually a little bit too posterior and a little bit too vertical to represent actual anatomic placement of a native ACL. So over the years they developed a much better solution, which was called the anteromedial approach, which you'll actually use an accessory porthole to do your drilling. You'll drill, kind of skim right over the anterior horn of the medial meniscus, and you're going to come through here into the medial wall of the lateral femoral condyle, and you're going to start your drilling, and you're going to go all the way through this interosseous space and out through the lateral cortex of the femur and out the skin of the lateral thigh. And so you're going to go ahead and drill that with a guide wire, and then once the guide wire is in position, I'm actually going to pull the guide wire out, and the next step would be to, I don't have a depth gauge, but you are going to pass a depth gauge through this medial wall of the lateral condyle, out through the lateral cortex, and what you're looking for is the total depth, which will be normally about 40 millimeters depending on the size of the patient and the size of the bones. And 40 millimeters is good because for optimal soft tissue kind of graft to tunnel interface and osseointegration, you want the graft to actually be recessed within the interosseous space about at least 15 millimeters, but you're shooting really for 20-25. And you don't want to ream all the way through, because you definitely don't want to puncture through this lateral cortex, because this is where your fixation point is going to be, and you don't want the bone to be too thin or it could pull through under heavy load at the knee. So you're going to reinsert the guide wire after you do your measurement, and then you're going to say this is the guide wire, and then you're going to select once again the corresponding, based on graft diameter, the corresponding fluted reamer, and you're going to drill to the depth desired, which is 15, 20, 25 millimeters. And so now you have a two-stage of diameter tunnel prepared. Okay, now the next step would be to prepare for graft placement, and this stuff here is all part of this assembly, which is going to help anchor the graft and pass the graft all in one. And this here is called, this thing is called a toggle lock. It's made by an orthopedic company called Biomet. And what this little titanium button does, it's designed to kind of capture the cortical bone of the femur. So what happens is that you're going to pull it through. This thing is going to flip and seat here on the lateral cortex, and this will provide your anchor point for your new tendon or ligament. And so the first step of this procedure, this is a passing suture or relay suture, and you're going to take this passing suture and you're going to feed it through your femoral tunnel. You're going to take both of the free ends through that. You're going to go through the anteromedial portal, pass through your femoral tunnel and out the lateral cortex, and you're going to pull it almost all the way up. Now you're going to go through your tibial tunnel and then pull this looped end of the first passing suture distally down through the tibial tunnel, so you have this open loop. And now you're going to take your prepared graft, which is this thing here. This is representing the actual soft tissue graft, so this could be a gracilis tendon or something. There could also be two of these, two strands, if the patient is going to, like a football player or something, and you want it really strong. And this is known as a whip stitch. It's kind of a simple mechanism to anchor this. These are going to be used later, and I'll show you that. So you're going to load the prepared graft over. Sorry, I want to untangle this thing. These come in a sterile pack. They wouldn't be all tangled up like this. Okay, here we go.
I assume you'd also be wearing gloves.
Not this guy. Okay. Okay, you're going to load your graft through this delivery mechanism. Okay. Now this is really important that none of this is tangled up. So here I have, it's hard to see from far away, but you want to make sure that this is the zipping strands. You want to make sure that these are kind of facing you or they're facing anterior. And you don't want any kind of bulging or knotting happening here when you're trying to pass this graft. It's very important you get these things all worked out. So everything here is perfect. And now, once this is ready, I'm going to take the free ends of this passing suture and pull it through this looped end of the first passing suture. And then you're going to pull this all the way through, and you can do away with this first passing suture. So now you're ready for graft passage. You're getting really close, so you're actually going to put the patient's knee at about 90 degrees, and you're going to pull this through. You're going to pull the toggle lock assembly through just until this thing pokes out the lateral cortex. Now once that is done, you can take the second passing suture. You want to get rid of that. And you're going to make sure that this is on the correct side when you seat it. And then you're going to pull back here, and as you can see how now it's anchored on the lateral cortex. Okay. Now the next step is to retrieve your zipping strand. You're going to go through the anteromedial portal here, and you're going to find your zipping strands, as you're not going to want to zip through the tibial tunnel, although you can. I believe it's preferred to zip it through the joint space here. So the next step is to actually start your graft passage, in which you're going to actually use this zipping mechanism. This whole contraption, this toggle lock assembly, is kind of like a Chinese finger trap, and it's going to start sucking this tendon up into the tibial tunnel, and it might help to kind of alternate strands. You see how this is passing through? Now, something I didn't do for lack of time is this tendon will have marks on it, and so you're going to go to the marks for your desired depth within the femoral tunnel, and then once you get to those marks, you kind of know where to stop. Okay, now that that's done, you're going to leave these zipping strands here for later. Now the next step would be your tibial fixation point. Femoral fixation complete, graft is in place. You're going to start your tibial fixation with a device also made by that company Biomet. This is called a tunnel lock, and this here is the actual tibial fixation. This is a piece of plastic basically that's going to become part of your body for the rest of your life. It's non-absorbable by the body. It's made of a polyether ether ketone substance. So you're going to insert it onto the tunnel lock device, and right here is kind of a tibial anchor. It's like a sharp point. You kind of jab this into the tibia. The first step with this is actually anchoring the graft to this tunnel lock device. You're going to pass the ends of the graft through this horseshoe portion of the tip of the tunnel lock. You're going to put these arms into position, these anchoring arms. Now you're going to wrap each end of the tendon several times around these posts, and you're going to cleat them so you have no slippage. Okay, now once that is fairly well anchored, you're going to, this is a ratcheting mechanism, so if you are to hold the handle and kind of ratchet back, you're going to keep ratcheting this back. Now what you're going to do at this point, actually not quite there yet, is you're actually going to hammer this. Can somebody come hold this for me? I don't want to destroy it. Got it? Hammer this tibial fixation all the way until it's flush with the tibia. And now what you're going to do with this thing still in place, you're actually going to cycle the knee, and you're looking for impingement here. You see this is your new ACL. You're going to be looking for impingement on this kind of intercondylar notch, and you can also do, now is a good time to go in and do a notchplasty, even to prevent further impingements if you feel like it. And you're also cycling the knee here is kind of like cyclic loading to get all the creep out of the system and all the stretch out of that new ligament. Okay, now that you feel comfortable with that, you feel like, because these zipping strands here will allow you to actually still increase tension even after your tibial fixation is complete. Okay, now these will actually get trimmed and will sit flush on the tibia here. And now you will do some more cyclic loading to get the remaining creep out. And if you feel like it still needs to be tighter, which in this case I believe it does, because what you're trying to do is provide rotational stability of the knee joint, and so it definitely has to be tight. So now here I'm going to actually do a little bit more zipping. See, I can't get that anterior translation anymore. It's doing its job. Okay. So at that point you're going to go in through your accessory portal or your anteromedial portal, and you're just going to cut the zipping strands, and then there you have your new tendon, your new ligament rather. So as far as recovery, that surgery there, you could probably do it in an hour, maybe 2, so it's pretty quick, and the patient might spend 2 to 3 hours in recovery and go home the same day almost every time. Physical therapy could start anywhere from 2 to 3 days after supervised physical therapy with an actual physical therapist. That'll last anywhere up to like 10 weeks, and after that you'll be given some instructions to do self-directed therapies at home. Total recovery time from something like this could be 6 to 10 months. Complications for women could be developing osteoarthritis of the knee, and it's very common. Maybe 50% of cases of women can develop it 1 to 2 decades post-surgery. So you're not in the clear until several years later to know if you're going to have this osteoarthritis. As far as the longevity and the quality of the new ACL, Once it's been placed and the healing starts, you're going to it's going to restore a blood supply to that tendon. Along with that blood supply, it's going to bring some fibroblasts. It's going to populate the tendon and essentially bring it back to life. So this ACL could be as good as new. I mean, I don't know if it could ever be better than your original structure, but I believe that the idea is that it could be as good as what it was, which is really, it's great, you know, for people that have to deal with this, you know. So I guess that's about it.
Thank you.
Any questions?